Thank you for joining us for the Sight and Sound Bites webinar series. This is a bi-weekly series that highlights research at the University of Pittsburgh School of Medicine, and it's brought to you by the Eye and Ear Foundation. Today's topic, using advanced imaging to treat and prevent vision loss. I think this is going to be one of those programs that you'll realize, the work here going on at the University of Pittsburgh. This is some of the work that really separates the work that's going on here from other places. It's really outstanding what you're going to hear about today. I'm Lawton Snyder, CEO of the Eye and Ear Foundation. The Eye and Ear Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of ophthalmology and otolaryngology at the University of Pittsburgh. The funds that we provide from the Eye and Ear Foundation to support research are only made possible because of philanthropic support. So thank you for all those who've supported us over the years. And thank you for those who may consider supporting the research you're going to learn about today. If you like to reach us directly, you can contact Mr. Craig Smith, who was in the email that you received about today's webinar. Just some housekeeping rules. This is a Zoom product. You recognize that, and all the buttons should be where they are when you use like a Zoom meeting. But for our webinar, we disable chat, so don't try to chat. But we do have questions and answers enabled. So the Q&A function at the bottom of your screen is what you use when you want to ask a question. Please feel free to ask questions at any time. We'll save them until the end of the program, and then I'll read the questions to the panelists at the end. But please refrain from asking personal health questions that wouldn't be of value for the whole audience to hear. So if you have questions that are more personal, please just email them to Mr. Smith, and we'll try to answer those for you through our experts. Please feel free to use the subtitle function for closed captioning if need be. And we will send out surveys on today's program. We appreciate hearing back from you related to that. And then we will keep you on our mailing list unless you ask us not to do so for future webinars. So to introduce today's speakers, we have our Chairman of Ophthalmology, Dr. Jose Elaine Sahel, Distinguished Professor and Chairman, Department of Ophthalmology, University of Pittsburgh School of Medicine, an exceptional class professor at the Sorbonne University in Paris, and the Eye and Ear Foundation Endowed Chair. Dr. Sahel, great to see you, and thank you for introducing today's program.
Thank you very much, Lonnie. So thanks for everyone for attending this webinar. We are going to focus today on something which is very essential in ophthalmology, namely imaging. We rely a lot on very careful observation of the lesions and the status of the tissue we are treating. We are very privileged in ophthalmology because the level of resolution we are reaching and the accuracy of the measurements we are performing are enabling us to follow the course of the disease, also to really refine the diagnosis and to determine whether the therapies that we are using are effective or less effective. So today we assembled some of the key people in the department that are working in this area, mostly focusing on the retina. So we have also very important work ongoing in both glaucoma and cornea and beyond, but today is going to focus on the retina. So you'll have two clinicians that are deeply involved in analyzing images, but developing also new tools for imaging and trying to use artificial intelligence to really optimize the type of information we are getting from this type of imaging. So these two clinicians are Dr. Kunal Dansingani, who is an associate professor of ophthalmology in charge of electronic activities, IT activities in the department, and has been working for many years on optical coherence tomography and artificial intelligence, and is an expert in retinal disease. So is also Dr. Jay Chhablani, an expert in retinal disease that has been very deeply involved in research on artificial intelligence and imaging the vasculature in the retina, and actually several very severe conditions. And you'll certainly be very impressed with the amount of work we have done, but more importantly, with the relevance to all the disease we have to cope with. And last but not least, we have Ethan Rossi, my first recruit when I came to this department 5 years ago, who is a world expert in high resolution imaging. So he's developing new tools for imaging derived from astronomy, from photonics, and more to come. Actually, thanks to some of our donors and sponsors, we are now able to go even further and have the type of equipment that nobody else has in the world, except my former team in Paris, but even others that nobody else has really. And so we are working together already, and we have this wonderful team of clinicians and scientists working together around disease, understanding disease, and treating better disease. But I think I will just stop talking and let them describe what we are doing. It's very complex, but they are going to try to make it as simple as possible. Obviously, we are here for you for questions today and after the webinar. So I'll start with Kunal Dansingani.
Thank you very much, Dr. Sahel. It's a real pleasure to be able to speak today and to have an opportunity to share not just what we're doing with the latest in imaging, but also to try and share some of our enthusiasm for this subject. To understand anything in imaging, we need to have a solid understanding of anatomy so that we know what we're looking at. So we'll start with a little primer on the relevant anatomy. We'll go through explaining a little bit about the different kinds of imaging modalities that we use to study the retina. And then Dr. Chhablani will take over to describe some biomarkers of disease with a focus on age-related macular degeneration, because AMD is such an impactful condition, and it also teaches us so much about the biology of the retina. And then Dr. Rossi will show you some of the latest techniques from his lab and some of the most exciting findings for today. Now, in ophthalmology, the scale of the tissues that we're working with necessitates the development of microscopes. And sometimes we call them microscopes, sometimes we call them ophthalmoscopes, but really these are all systems which are designed to magnify the tissues for us. And in recent decades, there has been increased digitalization of these microscopes and techniques, which allows for various forms of image processing and applications of mathematics and other techniques, which allow us to enhance the visualization of various biomarkers. And the most useful microscopes reveal the relationships between the anatomy, in other words, structure. They tell us about physiology, they expose aspects of normal function, and very importantly, they show us signs of pathology, signs that function has become aberrant. In the research that we do, we're really trying to push the limits of what technology can achieve. And simultaneously, we're also trying to push the limits of exploration and understanding. So if the material seems complex, it's because it is complex. And living at the edge of complexity is what we enjoy doing every day of our work. So I hope that comes across. Now, another thing to keep in mind is that imaging provides us really almost all the biomarkers that we need for understanding the effects of treatment. And this is why imaging is so important for clinical trials. And if you look at the history of the developments in imaging, you also see that advances in imaging have always occurred in parallel with advances in therapeutic modalities and vice versa. So that's also part of the motivation for this interest of ours. So starting with anatomy, here's a schematic of an eyeball in cross-section. And this is a diagram that many of you will be familiar with already. For today, we're going to focus on the retina. More specifically, we're going to focus on the posterior pole, which is this area back here. And even more specifically, we're going to focus on this small part of the posterior pole called the fovea, which is the part of the eye that's responsible for fine vision, for central vision. And it's the part of the eye where disease can have a very profound effect on vision. So to visualize the fovea, well, here's a color photograph of the posterior pole. This gives you an idea of scale. The fovea is about 1.5 millimeters in diameter. And this is a color photograph. So the color photograph is taken with white light or with a white flash. And this is the closest imaging modality that resembles what we see when we look into an eye with an ophthalmoscope. Now, color photographs are extremely useful, and much of ophthalmology has been built on understanding color photographs and on ophthalmoscopy. But there are also many other modalities that we use involving the use of various different wavelengths of light. And this is an example of a 3D modality called optical coherence tomography, which is able to take a cross-section through the fovea and show us the various tissue layers. And many of the layers we can see are layers of the retina. We can also see some of the bright layers which are deep to the retina. The brightest layer in this part of the image is the retinal pigment epithelium, which is an extremely important layer in many in understanding many diseases of the fovea. So optical coherence tomography has really become a gold standard in clinical imaging. We use it every day and on almost every patient in the retina clinic. Here's this is just really a list of keywords to illustrate the complexity of imaging. So we have different forms of reflectance imaging, different forms of fluorescence imaging, different forms of 3D imaging, and various techniques that we can apply. And actually, you can take any of these keywords in pairs and combine them to produce a new modality. So the various combinations of all these keywords, it represents a very large sort of a very large space for exploration. I'm going to show you just a couple of examples. So this is, first of all, in the top left corner, this is a color photograph of a patient who has had an interruption to blood flow in the retina. And on the color photograph, where the arrows are, you don't really see much. The findings are very subtle, even to a trained eye. The color photograph doesn't contribute that much to understanding this case. If you look at the optical coherence tomography, you see that there's a band of tissue within the retina which has increased brightness to it. We call that increased reflectivity, and it's casting a shadow on the structures behind it. And when we introduce another modality, which is infrared photography, it's the infrared photography which reflects off one of the very deep layers behind the retina. It reflects off the retinal pigment epithelium, and it shows us this area of loss of transparency of the retina in silhouette. So that grayish kind of figure that you see is a silhouette of the pathology, which is highlighted by this technique. Essentially, what this patient has had is something resembling a small stroke, but having had it in the retina rather than in the brain. And that figure that you see is the shape of the blind spot that the patient describes. Here's another example. This is a patient with an epiretinal membrane. So this is like a layer of scar tissue, which has gradually grown over the surface of the retina. And when you look at the color photograph, you can see that there are some spoke-like figures. You can see that there's some pucker of the retina, but the visualization of the epiretinal membrane itself is greatly enhanced by using different types of, by using different wavelengths of light. And what we see is that the blue reflectance image, which is taken with a blue flash on the camera, is the one that delineates the edges of the membrane probably best. The green flash also shows it quite well, but the infrared is almost able to see right through the epiretinal membrane. So this is an example of how we can dissect the components of the light coming back from the back of the eye to be able to unravel what is happening in different layers of the retina selectively. Here's an optical coherence tomography of the same thing. The image on the top is the contour of a normal fovea. It's supposed to have a little dip in the center. And the image below shows an epiretinal membrane, which has grown over the surface of the fovea and cause the fovea to be folded into these irregular corrugations. Here's another example. Now, this introduces yet another type of imaging called autofluorescence imaging. On the left, you see a color photograph of a patient's right eye. And if you look at the very center of the picture, you see that there is some alteration of the pigmentation in the area around the fovea. Now, that alteration of pigmentation is much more obvious to see on the autofluorescence image. And that's because the autofluorescence image is not so much a structural image, but it's an image of the distribution of certain molecules in the retinal pigment epithelium. There's a molecule called lipofuscin, which accumulates in the cells of the retinal pigment epithelium. So what you're looking at in the right-hand picture is really a distribution map of that molecule. And this is where the use of different kinds of imaging modality gives us not just structural information about what's there, but molecular information about what's inside the cells that we're looking at. At this point, I'm going to hand over to Jay Chhablani, who's going to tell you more about macular degeneration and more about the biomarkers of AMD.
Thanks, Kunal. Thank you so much, everybody, for joining this webinar. So like we started talking about imaging, so we should really get into more details into the imaging and see how do we use these imaging modalities in our clinical practice. So we are going to talk about age-related macular degeneration as the disease model, and I will show you some of the interesting examples that how we use the information which we get out of these different imaging modalities, as Kunal was just describing. So this is a very typical picture of dry AMD on your left and the wet AMD on your right. The picture in the dry AMD shows you some pigment clumping, drusen, which is a very characteristic finding in macular degeneration. And this patient also has something called as geographic atrophy. In layman's term, we call it as that the retinal tissue has really thinned out. And with the help of the OCT scan, which is shown at the bottom, you can see that how the dry AMD OCT shows clearly the retinal tissue has thinned out so much. Let's look at the picture on the right, which is a picture showing a wet macular degeneration where you have a subretinal hemorrhage. That means there is some bleeding under the retina. And by using the OCT, which is shown at the bottom on the right side, shows that we can actually look at the picture, look at the hemorrhage, at what level the hemorrhage is. And these are some of the findings which we use in our clinical practice and follow up. I'll show you how we use this. So as Dr. Sahil was mentioning, that we are lucky that we have imaging modalities which we can use directly on the tissues, and we follow up the disease processes and the treatment response. This is a very good example of dry macular degeneration patients. These are examples which I picked up from one of the very reputed journals, that is American Journal of Ophthalmology. These images are fundus autofluorescence images, which were just described by Kunal, where we are able to see these dark spots. You can see these pairs. They are the same eyes which have been followed up over the course. And you can see that this dark area, which represents the area of thinned out retina, which is geographic atrophy. And you can see that over the course, how the area of this atrophic part has enlarged over few years, or it all depends what kind of atrophy you have. So we use these images to document the atrophic area and to quantify this atrophic area. And this becomes kind of a biomarker which helps us to understand the disease progression. Let's look at another example of dry macular degeneration. Here I've used one of the examples where we are showing a multimodal imaging. Here you can see the picture on the leftmost is the color photographs. Then this is a fundus autofluorescence image. Then this is an infrared image and the OCT scan passing through the central part of the retina. Now let's look at these pictures of the same patient ranging from baseline to visit 1, 2, 3, 4, 5. Here you can see that how we can scan exact same area and we can follow up these images so closely. Now I would like you to look at this OCT scan, which clearly shows that on the topmost image, there are some changes which are essentially because of the dry macular degeneration. And you can see that how the outermost layer, which is retinal pigment epithelium, it starts thinning out over the course. And this eventually leads to an atrophic area, which is involving right in the center. And these corresponding changes you can follow up on these multimodal imaging modalities. Let's move on to look at the wet macular degeneration. We already learned that wet macular degeneration will have some amount of subretinal hemorrhage as shown on this color fundus photographs picture on the top left. And now let's look at these OCT scans. The first OCT scan here shows that there are some findings which are supporting the presence of wet macular degeneration, such as this area, which shows a subretinal fluid, that is, there is some fluid under the retina in addition to the blood. So what we do, we start the patient on injections, and then we do these sequential OCT images and see our treatment response as shown here. As we move from the image C to D, we look at these pictures that, oh yes, there is some response, but still there is some fluid. Your doctor will offer you one more injection, and eventually this patient has responded really well. And the bottom image, you can see that the same patient, there is no fluid. There is some lesion which is still there. However, there is no activity as such for which we need to do the treatment. Then what we do, we stop the treatment. However, we would continue these OCT scans in the subsequent follow-up visits just to make sure that if there is any signs of recurrence on these scans. Because these scans are taken at such a micron level, it is possible to pick up the disease activity so soon on these scans compared to our examination or on these photographs. So that's why the OCT becomes a backbone in the management of wet macular degeneration, as well as many other diseases such as diabetic macular edema or central serous. Let's move on to another interesting modality, that is OCT angiography. This is something new which has been introduced in the field of retina, where we can image and look at these abnormal vasculature, as you can see here, non-invasively. That means we are not injecting any dye, but we are just taking pictures of the eye, which are showing us these abnormal vasculature. And here you can see sequential images of a patient with wet macular degeneration, and this vascular network keeps changing with the treatment, and this helps us to decide whether we have to continue the treatment or we have to switch the treatment. So we actually use these modalities, quantify these changes, and use them as our biomarker. That is where the use of artificial intelligence plays a role in our retinal imaging. This is an example of a patient with wet macular degeneration. Here you can see that the patient has a disease activity, which is shown as this thickening of the retina, which we call it as an intraretinal fluid. And then you have this pigment epithelial detachment. And on this column, you can see that with the help of artificial intelligence, now we are able to segment out these lesions, quantify them. And on the picture on the right clearly shows that how the disease profile can be generated just with the help of various ways of looking at the same scans. And then we start quantifying this, and we are hoping that we will be bringing these information in our clinics, and so we can follow up our patient much more accurately than just clinical exam. This is some of our work which we are already doing here at University of Pittsburgh, where we are trying to quantify these various biomarkers such as subretinal fluid or pigment epithelial detachment. Here you can see these 3D segmentation of these biomarkers, which we are able to quantify, and then we will be able to follow up these patients much more closely. This is another example of choroidal segmentation, where you can see that this is a layer under the retina which plays an important role in various diseases, more importantly, age-related macular degeneration. And this is the work which we have come up with, where we can segment out the choroid and then start quantifying. And now we are using this as one of our biomarkers. With this, I would hand it over to Ethan, who is going to talk about much more advanced imaging, which we are really excited about. Thank you, everybody.
All right, thanks, Jay, and thank you, Kunal. That was a great setup for my section here, where I'm going to be talking about some novel techniques in my laboratory for looking at age-related macular degeneration. And so I just want to first start by giving you a spatial scale of the level of detail that we're going to go down to here now. And this is looking at the external eye. And that's about 10 millimeters across there, across the iris. If we look at what 10 millimeters looks like on the retina, that involves that central area of the macula. We'll go 10 times more than that, and then we'll zoom in 10 times more again to get down to the level where we can see the individual cells in the back of the eye. And here in this image, these larger structures are the cone photoreceptors, and the smaller structures in between are the rod photoreceptors. And we can achieve this level of resolution through a technology called adaptive optics. That's a technology that was developed for space surveillance originally, and then has been adopted for ground-based astronomy. And the concept of adaptive optics is that it allows for both the measurement and the correction of aberrations in an optical system. And when we think about astronomy, we think about those aberrations coming from the atmosphere. And so this is an example here of what the planet Uranus looks like with no AO, and then with AO, you can see massive improvements here in the resolution. It allows us to see, in the case of a star here, where there's actually two stars there. So the adaptive optics can resolve this binary star system. And then one of the most important findings from adaptive optics here is in the lower right corner, where this technology has allowed us to look deep at the galactic center and be able to see the stars orbiting around the black hole in the center of our galaxy. And that was only enabled through adaptive optics. The benefit for retinal imaging is that when we turn the adaptive optics on here, and this is in one of our scanning laser ophthalmoscope systems, you can see that the adaptive optics does three things. It improves the contrast, the resolution, and also the throughput. So it gets more light through our imaging system and allows us to see now the individual cells in the back of the eye. This image is moving around because the eye is in constant motion. And so when we use a technology like that, we apply a type of image processing where we can undo that motion and average those images to improve the signal, reduce the noise, and get pictures that look like this of the photoreceptors here on the left. This upper left image here is showing the tiniest cones that are right at the center of that foveal area that Dr. Dansingani had mentioned is the area that we use for reading. And it's this area that is really important for so many of our visual capabilities, such as recognizing faces and driving and doing all the things that we do every day. Those of us that are able to see at night take advantage of the rods here that we can see in the lower left corner. The little tiny rods here are interspersed between the larger cone photoreceptors. Now, this is when we're focused on the outer part of the retina here. This little cartoon in the lower right corner shows you that the retina is a very complex optical structure. It's many layers thick. We could see that on those OCT images where we could see the different layers of the retina. Now we're looking at the cells here. And when we're focused on the back of the eye, looking at the photoreceptor layer here, we can see those cells very well because those cells scatter a lot of light back out of the eye. But when we focus up on this intermediate layer of the retina here, where there are also lots of different classes of cells, we don't see much in this here, this confocal mode, we call it. So we're looking at the backscattered light that comes out of the eye. And if we are then able to take and focus now up on the nerve fiber layer of the retina, that's the top layer of the retina, we can see here the individual bundles of axons. So those are relaying the information that has come from this top layer of cells, the ganglion cell layer. To see that layer, we have to use a different type of way that we detect the light. The technique here that I'm showing is something we call multi-offset adaptive optics. And that allows us to now get access not to the light that's really directionally backscattered from the retina, but light that sort of scatters multiple times through different tissues. And what that reveals to us are the structures that are really weakly scattering. The reason why these structures do not scatter much light is because they need to be transparent so light can pass through them to reach the photoreceptors. Because as this little cartoon shows, the path of light here is in this direction. So light has to pass through this layer to reach the photoreceptors to allow us to be able to sense light. Now, for age-related macular degeneration, we're really interested in looking at the outer retina and this area here of the photoreceptors and the RPE, and this retinal pigmented epithelium layer that sits behind the photoreceptors is critical for maintaining the photoreceptor health. And the images here are produced through fluorescence imaging, which Dr. Dansingani also mentioned. And so this, the contrast in this image arises from that distribution of those molecules, those fluorescent molecules within the cells. And in this way, we can reveal now the hexagonal pattern of this layer of cells that sits behind the photoreceptors and maintains their healthy function. We can compare now what a patient with AMD looks like on the right to a patient or to a normal eye on the left. And you can see that in our patient on the right here, there's a real massive redistribution of these fluorophores that can occur at different stages of the disease. We've been using our adaptive optics fluorescence imaging to look at patients with age-related macular degeneration to begin to understand how these changes in the distribution of those molecules can be used to understand the earlier stages of disease. So this is on the bottom here, we can see the OCT image, and we can see here that there is some disruption to some areas out here of the different layers. The area though that we're looking at up here is sort of spans within this region where things do not look so altered as they do in the fluorescence image up here, where we see some really massive redistribution of the pigments. If we look at these layers, we can see the outer layers are not as distinct as they usually are, but it's interesting to see such a massive redistribution of fluorophores at this stage, where our clinical images from OCT suggest that the outer retina is still intact. This is another example here where we can look at the photoreceptors with our confocal imaging in a patient with AMD, and then again here compared to the fluorescence, where we can see in areas right here by the fovea that there's been a loss of fluorescence corresponding to many cells. If we zoom in on this region here, right in the center of the fovea, this area here where there's this depression is the center of the fovea, and we're zoomed in here now looking at those photoreceptors. You can see in areas where the loss of the fluorescence has occurred, we can see the photoreceptors are still intact, but that they don't reflect light as well. And we think that this is an early indication that the photoreceptors are being altered due to these changes in the RPE cells. And we are interested in using this as an early indicator of changes that may be occurring that we can't detect that well in the clinic. Another exciting use of this type of technology is for looking at changes over time. And so here is an example of an image from the clinic that we can overlay now one of our adaptive optics imaging modalities on. This is a different type of adaptive optics that we have in a commercial prototype system in the lab. And this type of adaptive optics imaging is really spectacular for looking at changes over time. And so now we're looking at the lower left corner here is telling us the date. This is the progression now of this geographic atrophy now over the course of 1 year. One of the things that has made age-related macular degeneration challenging to understand and to study is that it is a very slowly progressing disease. And so having new imaging tools that can be able to track the progression of AMD at very short time intervals is really advantageous, because it is helpful not only for us to understand the progression in that particular patient, but it's also helpful as a tool to be able to look at the efficacy of new treatments, because when we have a very slowly progressing disease, it takes much longer now to see if there has been an efficacious result from a treatment. And so we can apply these tools now to look at shorter time scales. Another thing that we've done with this type of adaptive optics that we call flood illumination adaptive optics is apply new image processing techniques to enhance the contrast of structures like drusen. And here we can compare, now this is the native image, the lighter colored one here, to the one with these high contrast contours. And these actually are tracing out now the boundaries of this complex pattern of drusen that we really can't see so well from the native adaptive optics images. We are excited about this new approach because it's allowing us, we think, to detect some microscopic drusen structures that are at the earliest sort of stages. Now these drusen here that are highlighted with these yellow arrows, we can't see them in the color fundus image. And really in the native, this is the FIAO, the adaptive optics here, this image doesn't show them that well really either. It really doesn't show much of anything in this area. But when we apply this image processing and what we call this gaze-dependent imaging technique, we can see here these tiny structures that we think are drusen. We think they are the precursors to these larger drusen that we see, because we've looked at longitudinally many patients now. We've applied this in over 100 patients, and we can see these grow over time and turn into the more common drusen that we can see here on the color fundus, like the ones indicated with the white arrows here. This is an example of sort of putting into motion now the progression over a few years from one patient. And there's a couple interesting things to highlight here. This is showing this dashed line, the original extent of this druse at the first time point, and we can see it now expanding over time. This arrow here is pointing at few individual drusen that then coalesce and merge into a single druse over time. And then down here, we see two of those tiny little sort of micro drusen structures evolving over time and coalescing into a larger drusen. So we're excited about this approach. This is a technique that we just published. The paper was just accepted. And so we're really excited about that. I couldn't do this work without my great team and all my collaborators here. I'll just stop now and we can have some questions.
Well, thank you, Ethan. Thank you, everybody. This, again, as I said in the beginning, this is one of the exciting things that we have going on here at the University of Pittsburgh that really is, you know, I feel, you know, getting to a lot of answers to a lot of problems that are out there for people with vision loss. And as I can see, we already have a lot of questions on the board related to that. So first one, I think would be a nice point of clarification for maybe some people that don't know the difference here. What is the difference between wet and dry macular degeneration? Kunal, go ahead.
Sure. Yeah, really important question. So macular degeneration is a degenerative process, and as such, it's characterized by loss of cells, and it's characterized by degeneration of some of the connective tissue layers, which are there among the layers of the retina and some of the deeper structures. Now, in dry degeneration, there's always a little bit of dry degeneration. There's cell loss, there's degeneration of these layers. One of the things that can happen is that as some of the barrier layers degenerate, they can allow the growth of blood vessels in undesirable patterns. And this is something that Jay was showing on his slides, that the growth of blood vessels into compartments where they don't belong can result in leakage of fluid, leakage of protein, and sometimes bleeding as well into some of the tissue compartments. And the combination of protein and blood coming into contact with the photoreceptors of the retina can accelerate the demise of those photoreceptors. So it's not so much about wet versus dry, because there's always some degree of dry degeneration, but there can be the wet complications on top of it. So I hope that helps to clarify.
Thank you. Someone described it once to me as you have a sidewalk that gets withered and starts to crack, and then you have the grass that grows up.
That's a very good analogy, yes. Yeah.
So from a patient's perspective, is there any difference in how the various imaging modalities are done, or will they feel the same for a patient who's getting one type of modality versus another?
Dr. Rossi has a lot of experience on the engineering side of this. So he may be able to explain very elegantly.
Sure. From a patient's perspective, I think the various types of imaging modalities that we have in the clinic probably all will sort of feel the same way to the patient. They're relatively quick. There are different wavelengths of light that are used, as Dr. Dansingani explained, and occasionally we'll use visible wavelengths of light that can appear quite bright to the participants. Now, we are very careful about, you know, the light levels and everything that we put into the eye, and so all of these different light levels that we use are perfectly safe, but they can sometimes appear to be very bright to the participants. And so that's one of the reasons why we've begun to try to move towards using near infrared wavelengths of light. Not only do they reveal certain structures with much higher contrast, they also are much more comfortable for participants because they're in a part of the spectrum that we're not that sensitive to, so we can use equivalent levels of light or even more light than we typically could at visible wavelengths, and those will all appear at a very comfortable brightness to the patient. In terms of the difference between the research imaging and the clinical imaging, the major difference that participants would experience is that the research imaging typically takes a little bit longer than the clinical imaging modalities. And that's partly due to our much smaller field of view, because when we zoom in down to the cellular level, we have a much smaller field of view than is seen clinically. And so to be able to acquire an image that's large enough to fill up the area that we're interested in from the clinical perspective, we need to make several measurements, take several images and stitch them together. But that's really the main difference is the amount of time that the imaging takes.
All right, well, thank you so much. Are you working on any imaging techniques to take the place of field of vision testing, say for glaucoma patients?
There are, I don't know if Jay and Kunal might weigh in on this one, but there are some new advanced imaging techniques using adaptive optics that are emerging to be able to probe the function of the retina without having to ask the patient whether they saw the light or not. And this family of techniques that's being developed right now are called optoretinograms. And that's a method now for being able to probe the function without having to do something that we call psychophysics, which involves, presenting lots of different levels of light and asking you whether you saw it or not. Those types of measurements can be, prone to a lot of noise and are not necessarily as precise as these types of tools that now can probe and look at function independently, just using lights. And so I think those are eventually going to be make their way into the clinic, but they're at pretty early stages now. But it would be a type like that would be something that would be able to, I don't know if it would completely take the place of types of testing that we do, but it would also be, a complementary approach to get at this question of how is the retina functioning, and doing that without having to ask the participants what they see.
Okay. Thank you. And how do you know which imaging to use on each patient? How do you decide which ones you want to use? That might be one from one of the clinicians.
It's a really great question. It comes down really to understanding how light interacts with tissues, and also developing an understanding of what happens to the tissues under different disease conditions. So part of that is training, part of that is experience, but it comes down to putting together the pieces of information about disease, about physics, about light, and about interpretation of the images to formulate the scheme of investigation that answers the questions that we need to answer for a particular patient or a particular disease. And then on the research side, we're always looking to push the boundaries of what we can quantify by applying new combinations of either imaging techniques or processing techniques or variations on those. And there are certain protocols which are very well established in the literature, which we would say are the conventional protocols, but then there are the experimental protocols which we're investigating the merits of.
Well, I think that the next question is really about what research we're doing. I think I'll summarize, but essentially with the ability to see degeneration as we are with imaging, are we simultaneously creating different methods to treat the degeneration? So the question is, can we anticipate a cure for AMD from what we're learning here?
That's an excellent question. It's a really important question. Maybe it's easier to start with the wet AMD, where there is the growth of abnormal blood vessels. One thing about abnormal blood vessels is that once they get beyond a certain size, they become established. Once they become established, they're not going to go away completely. So the best that we can do is to control their behavior, to control their leakage characteristics, and reduce the propensity for them to bleed. We also know that if you try to be very aggressive by trying to eliminate abnormal blood vessels, you can compromise the retina, because once those vessels become established, the retina kind of becomes somewhat dependent on them as well for oxygenation and for nutrients and for metabolism. So the answer to that question lies in trying to get earlier and earlier in the AMD process and trying to halt it at an earlier stage. And this is a very important question on which Ethan is focused. The subject, an important research theme of his is using all this imaging to try and understand the very earliest divergence of abnormal aging from normal aging. Perhaps Ethan would want to say a couple of words on this as well.
Sure, yeah, and Dr. Dansingani is talking about our study that's supported by the National Institutes of Health to look at and understand how the different cell mosaics in the eye change with normal aging, and how we can be able to detect age-related macular degeneration at its onset, which is not typically something that's defined clinically in a very quantitative way. We typically, when we look at patients that have early aging-related changes, that'll sometimes be called age-related maculopathy, which is sort of a precursor to age-related macular degeneration. But really, one of the things that we really want to understand, because age-related macular degeneration is very slowly progressing and it progresses at a variable rate in different individuals, what we want to know is what participants in our studies or what patients in our clinics are the ones that are at the greatest risk to developing severe vision loss from age-related macular degeneration. And ideally, we would want to catch those patients at the earliest stages so that we can begin, as Kunal said, to develop treatments that could halt AMD at its earliest stage and prevent progression to that stage where vision loss occurs. And so we're building now a big cohort across the human lifespan to understand at a cellular level how we can use imaging to be able to understand normal aging and differentiate it from those earliest stages on the path towards AMD.
Okay, thank you. I see a few questions actually for me here, because someone asked, and I mentioned at the beginning of the program, that if you have personal health questions, to send them to Mr. Craig Smith. His email is in the invitation you received about today's webinar. Feel free to send those personal questions to Craig. And there is a few here that I'll pass over, but we will get back to you with those questions pertaining to your personal eye health after we send those to the specialist. So with these new imaging technologies, will we be able to, will they be used in examining conditions other than macular degenerations, such as punctuate choroiditis, degenerative myopia, and other diseases? I guess in general, for more than just AMD, right?
Absolutely. Absolutely, we do. And we have several different studies ongoing right now where we're using these tools to look at other conditions, including inherited retinal degenerations and glaucoma and other diseases of the outer retina. So these tools are really a general purpose toolkit for being able to probe the structure of the retina at a cellular level across any condition that's affecting the retina, really. And one of the goals of my lab is to give us the tools to be able to look at any class of cells that we want to look at within the retina. And one of our projects right now is focused around being able to detect and monitor and understand what cells remain in certain retinal degenerations so that we can understand at what level to go in and then treat to restore vision using various different approaches, such as the optogenetic approaches that Dr. Sahel and others have been working to develop over many years to restore vision. So these tools we absolutely can use for other conditions, including those that you mentioned, to be able to really understand the cellular level changes in the living eye of patients.
Okay. All right. Another came through actually in the chat, which apologize, we must not have disabled chat, which is what we typically do when we set this up. But so when should individuals request that their health system use these technologies to diagnose AMD? Essentially, are these ready yet for most eye clinics for some of these technologies?
So much of what we showed in the first half of the presentation, myself and Jay, those are clinical imaging modalities. Not all of them are present at every clinic or at every office location, but OCT certainly is, dye angiography certainly is. So most ophthalmologists have access to the tools that are needed for state-of-the-art care. What we're trying to achieve here is to innovate beyond that and to apply new ideas, new image processing techniques, and to try and detect some of the nuances of retinal disease which are not detectable by conventional methods.
I'll expand on that question even for myself. So my mother had age-related macular degeneration, and I'm in my 50s now. So do you foresee a point in the future where people who maybe have those risk factors would eventually get imaged just to see if there's any disease progression starting as a routine process, just like you get sent for different diagnostic tests just to pick up early signs of cancer or other types of conditions?
Yeah, that's a very interesting question. That's really a question about screening and the merits of screening. There is literature about this in the public health literature. And essentially what it says is that screening makes sense when you've got something that you can offer as a result of early detection.
The treatment, right.
Yeah, now, of course, individuals would always like earlier screening, and very often they would like it even if there isn't something to offer, just so that they know what to expect. And certainly prognosis is something valuable that we can offer. So yes, I think the final answer is yes, there is value in screening, and we do anticipate that with improved detection technologies and less invasive detection technologies, that screening will occur at earlier and earlier stages.
Okay.
I'd maybe just add on to that as well to say that some of the work that we're doing right now is aimed at trying to understand what are those risk factors. And one of the things that we're looking at is the genetics of our participants and trying to understand how someone's genotype shapes the structures in the retina and what we call the phenotype at a cellular level. So that we can potentially begin to build a comprehensive set of biomarkers, including genetic risks, to be able to understand what patients are at the greatest risk for vision loss from AMD. So I would say we're not there yet, but we're doing the research now to set the stage for that to eventually occur.
Well, thank you all. I think we've covered our questions here. Any parting words from the group here? I see Dr. Sal, you're still with us. Anything you'd like to end the program with? Oh, you're muted here.
No, I think as you have seen, there is a spectrum of technologies. Some are already used daily, and nobody could even dream of that 20 years ago. That every day we are getting this high resolution, non-invasive imaging that is not even sending a lot of light into the eye. And everything is improving so fast. And we have a couple of new technologies that are going to be implemented in the next few months, but really very few, if any, centers will have. So this is a moving target all the time, but thanks to the support actually we got from several of donors. I want to mention Ron Salvetti, for example, but also the Shear Foundation, the Hillman Foundation. We have been able to really build new equipment, continue to work on that, and get funding from the NIH and others, and more to come. The goal really is to improve the quality of care we provide, the accuracy of what we do, and also the predictive value. Talking about the genetics, for example, in the future, we may target the treatments depending on the genotype, and this is what we are preparing currently.
Well, thank you. It's wonderful to see the progress. And even in the short time that, Dr. Sal, you built the team that's working on the imaging and enhancing the imaging, for patients here in Pittsburgh. It's phenomenal to see the progress, and you certainly can see that it's going to offer a lot more for patients in the future by just essentially giving all of you better tools to understand the process of disease. So thank you all. This is very exciting, and we hope to provide updates every so often as things are progressing. Thank you all for joining today's webinar, and have a wonderful Friday afternoon, and we'll see you back in a couple weeks for our next program. Have a wonderful day.
Thank you.
Thank you.
Thank you.